I explained to you last week, Dr. Raquel is a professor of psychiatry at the University of Pennsylvania. She's the director of the Brain Behavior Laboratory at the university, where they're doing extensive research in schizophrenia as a brain disease. Dr. Gur has both a PhD and an MD. PhD in psychology and an MD with a specialty in psychiatry. And I won't take a minute more of your time. Raquel?
Okay. What I'd like, if I can have the slides on, we'll just start. Some of them were just recently made and they're not, they're homemade, so they're not very good. We just didn't have a chance in the past week and we were stranded Monday and Tuesday, so we couldn't come in. Okay. Yes. Yes. Last week, we have covered issues that relate to phenomenology, how to the typologies that exist in schizophrenia currently, and issues developmental approaches, and some of the genetic studies. Today, I will, and we touched upon neuropsychology. I will briefly go over neuropsychology and then proceed to neuroimaging and neuropathology. So this will give you a range of going from the phenomenology, clinical features, to brain studies in schizophrenia. And I'm trying to cover a lot, so it's really sort of summarizing domains, because each one of these could have been really a full lecture just by itself. So let's pick up where, well, today's a sunny day, so it's okay. We'll just pick up where we stopped, and what when you can't see well, I will just use this as a guidance for myself, and I will tell you what is on the slide. The study of neuropsychology, namely the study of brain and behavior, is an opportunity to measure, when I say measure, I mean that it's quantifiable, in a standard fashion, behavior that are manifested by people, by individuals, and relate it to what we know the brain does. And because the behavior in schizophrenia is so aberrant, it is no wonder that when you try to relate it, as I did last time, to frontal lobe function, temporal lobe function, subcortical, cortical function, that you almost can't help but say, gee, I bet that there are some deficits there. And most of the studies up to now have looked at cognition, which is the first thing there, and they've examined intellectual functioning, a range of intellectual abilities, and have focused more specifically on 3 domains: attention, memory, and abstraction. Because these abilities or faculties are impaired in schizophrenia, and you can also tie them to brain function, so that attention and abstraction are more related to frontal lobe function, and memory more to temporal lobe function with connection to the frontal lobe. So there have been many research paradigms in the clinical setting that have used extensive tests and have demonstrated that patients with schizophrenia who are free of anything else, all they have is schizophrenia, are significantly impaired. Another domain that was raised last time at the end, and I will just touch upon, which is really a new area, an exciting area for research of schizophrenia, is the study of affect or emotions from the perspective of brain function. Most of what we do behaviorally from the perspective of brain function in schizophrenia is cognitive. Why cognitive? Because it's much easier. Cognition was invented as a research area well before it was fashionable to do it in schizophrenia. I mean, it's really World War II, unfortunately, gave the impetus to it. When you had many soldiers with brain lesions and who before were young and doing well, and suddenly they're not speaking well, they don't perceive visual spatials arrays, they can't recognize faces of people they know when they come back from the war, and you say, Jay, wait a minute. What did the lesion do to their brain and their behavior? And this is when extensive documentation, this was well before neuroimaging. We didn't have the luxury of putting somebody in the scan and saying, here is the stroke or here is the gunshot wound. You had to really like putting it by a puzzle and see many people and say, well, this is the behavior, characterize it meticulously, and then wait for post-mortem after they died and say, it must be this brain region. And this is the old theory of brain and behavior has developed. Emotions, because they're so complex and hard to quantify, has been sitting on the side. And what I want to do today is just give you a glimpse of what is happening right now, because this is where a lot of effort are going, because emotions are such an important feature in all psychiatric disorders and definitely in schizophrenia. All right, so just to show you what is the approach that is done to study cognitive abilities in schizophrenia. There are two approaches. One, you pick up one of these functions, attention, memory, abstraction, learning, and you develop either standard tests that are available in the literature and have known qualities, and you just zoom on them, and all you do is that you look at this specific function in schizophrenia. If you just do that, you cannot say anything about how does variable A, for example, memory, relate to variable B. Maybe if you go all gung-ho about deficit in one area, area A, and you have not measured something else, maybe it's no big deal. A is deficient, but if you measure B, C, D, E, F, they're all deficient. So why did you come up with a whole story about area A when everything else is not working? And this is especially important when you study schizophrenia, because it's a diffuse disorder. It's not like these people are well, except there's one weak area. You're talking about profound impairment in everything that is human. You know, all behaviors, social behaviors, everything that we have gone through last time are impaired. So it's very unlikely that we'll be talking about everything is just normal and average in one area. People like that do not have schizophrenia commonly. So the approach that has been adopted by most investigators is to say, let's spend initially at least some effort, get characterized patients where we know a lot about them, and get a profile. It might take a few hours, not one session, a lot of patients and expertise in studying psychotic patients, but we will get a profile of all domains of cognition. Then we can see if some areas are differentially impaired. Okay? And this is just now, I'll show you an illustration of how it's done. This is what I call a profile. And to have a profile, what you need is first, you need a characterized patient population where you measure a lot of function, abstraction, verbal abilities, spatial abilities, semantic memory, visual memory, learning, language, visual sensory motor, auditory and motor skills. So all of these tests, and each test has many questions, not like one question that maybe if the patient is attending to some internal stimuli, they missed it. You give them a lot of questions, so what you get is reliable. It's analogous to having a clinical interview. You try to probe from different directions rather than just you ask one question, they tell you yes or no, and you say, all right. You know, it's more complex than that. So you have administered this test, and you come up with a profile. You must have a normative sample so that you can say patients with schizophrenia are impaired compared to whom? To normals. The line 0 at the top, the solid line at the top of this rectangle, is by definition the mean of the sample of normal people. And these normal people must be carefully screened so that they have no schizophrenia, schizophrenia spectrum, or any other major psychiatric disorder, axis 1 or axis 2. So they're indeed normal people. And they have to go through the same battery of tests of MRI to rule out any developmental abnormality, anything, as the patients with schizophrenia. And then you run these people, and what you find is not everybody is the same. So that's why you get a mean for all of these functions as the normals. And you define this mean as 0. This is the flat 0 line. And then you ask, how many standard deviations are the patients with schizophrenic deviate from the mean? If they deviate positively, and you can see that they don't, because there's no top part to this graph, then you say they're above the mean. If they deviate negatively, what you see right here is that you say they're below the mean. And you can see that this graph, unfortunately, is drawn all negative. These are called z-scores, or standard deviations from the mean. The more negative you are, the worse you are off from the mean. And you can see that for the patients with schizophrenia, they're all in the negative. Now, these people are not mentally retarded. They've never been mentally retarded. They did not go to special education. They attended regular schools until the disease struck them, okay? They are compared not to normals who are the same as far as the level of education, but the parents, where they originated from, is the same. Because schizophrenia, almost by definition, when it strikes a person, interferes, in most cases, with their ability to achieve their potential. So if you have somebody who is 11th grade, maybe they were meant to be college graduates, but because of schizophrenia, they dropped out. So to compare them to somebody, a normal who is 11th grade, is probably not right. You look at the parents and you say, what is the education and occupation of the parents? So you match the samples and you say, this was the potential of them. And this is it's an interesting issue. What do you compare patients with schizophrenia to? And what we claim, you go back to the origins, because the disease, by definition, with its developmental characteristic that we discussed last time, is going to affect the ability to attain the potential. All right. So what you see is, number one, the profile, this line, is suppressed and impaired across the board. There's not even one function where they are average. They are impaired as a group across the board. The other thing that you see is that there are a few areas at the bottom. Semantic memory, it's memory for verbal material. Visual memory, memory for figurative material. And learning of information that are more impaired than anything else. And that significantly, it's not that the difference between these three areas and the rest that might occur by chance, only 1 in 100. So you know there's something there. What's interesting is that the brain regions that are important for this function are in the temporal lobe. So you can see how the behavioral data supports one of the hypotheses, that is the temporal lobe that is developmentally never reaches normal development. Now you might say, all right, these people are all young, mean age is about 26, they're not chronic, they are people who have been in and out of the hospital, so they're people who are able, between episodes or relapse, to function in structured setting in the community. You say, well, still they've been ill for a few years, they've all been on medication. When they're tested, they're not on medication. Maybe the effect of medication, neurotoxic, etc. Stigma. I want to tell you that unfortunately, when you take individuals who are very young, 18, 19, presenting for the first schizophrenia admission, never treated before, the first psychiatric encounter, they look just the same. So it's not the effect of treatment, it's not the effect of chronicity. They look very similar. The graph is just a little bit above this one, but it's very, very similar. Now it takes a lot of effort to alert all treating facilities in the Philadelphia area. Before you treat them, send them to us. We are interested in first episode. But this is a way of teasing apart the effect of treatment and chronicity. So when the question comes up, is it possible that because of treatment with neuroleptics, we introduce sort of brain damage in the patients? My answer is not. We don't. We ameliorate their symptoms the best we can. The pattern of cognitive disturbance is there day one when they present. And now we have followed some of these patients for 2 years. And some of them have improved, and some of them have not. The deficit maintains. It looks like more rather than a state variable that relates to the acute psychosis, it's a trait variable. Attention improves a little bit. when they are more together. But the difficulty in learning and remembering persists, regardless of the clinical improvement. So we know that this might be something that is sort of is hardwired and is present early on as far as cognition. I think that the next slide, yes, is on neuroimaging. And before that, I promised I will say something on affect. And here we go. Affect is very, very tough to study. Most studies of emotions rely on self-reports of people regarding, how they feel. And it's very hard to do, extremely difficult to get sort of the same respectable type of measures. There's a large literature on expressed emotions in the families of individuals with schizophrenia, suggesting that it's not the level of emotions, more negative affect expressed is higher, and maybe this might be related to the schizophrenic process. There have been a few studies, really very few, on emotions in schizophrenia that try to build up good data and relate it to clinical features and to cognition. And let me tell you just briefly what we have done. If you look at emotions, you can look at it the way you look almost at language. Perception of emotions, or put differently, can you read it correctly? If somebody looks happy, can you say this person is happy? The other component is the experience of emotion. How do you feel? Do you experience a full range of emotions? The third one is expression. So you are going from perception is more posterior brain regions. Expression is more anterior brain regions. And what we have done is develop a standard battery so that all the stimuli that you show are standard. It's not like you smile and you tell the patient, how do you think I look? I mean, am I happy or sad? It's unstructured. It's not good enough. We've developed standard battery, and maybe next time when I talk, this will be ready to present, a standard battery of people, actors and actresses, who are professionals expressing emotions, so there's no question that the face looks happy or sad. And then we presented it to patients with schizophrenia, normal controls, and patients with depression. So we have another psychiatric control group. Turns out that patients with schizophrenia, they understand the instructions, but they have difficulty reading emotions. They can see a face that most, even little kids, we've tried it with little kids, will say is happy. I mean, it's just intensely smiling, all signs of happiness. And they will say, most commonly, it's neutral or it's sad. And they can see a face that is sad, and they're more likely to call a face that is sad a little sad or neutral. They do not perceive emotions correctly. That's important because it might be, and this will come up to a question that you asked last time about the families, it might be that to tie it into all the domain of expressed emotions, maybe the parents or family members of individuals with schizophrenia indeed express emotions intensely. Maybe it's because the affected individual, the patient, cannot read emotions, and that's why they express it so intensely. Because a normal expression doesn't lead to communication. Now, what's interesting is the brain region that is in charge of emotions is closely linked. The amygdala is closely linked to the hippocampus. There are links that is in charge of learning and memory. So we are beginning now to make headways in trying to link the two together. So there's another thing that has come out, will be coming out by Elaine Walker. Elaine Walker at Emory has been using home videotapes of adults who now have schizophrenia, went back to the families and asked them for homemade movies. Now, granted that these homemade movies were done usually, most families, under good circumstances, a birthday party, a holiday, I mean, most parents do not just stand there for a day and just shoot common events. You just, you know, you pull out the camera, the videotape, and the special, or the recorder, and the special events. But what she's done, she's taken a group of judges, and she videotaped, she looked at the videotapes of individuals, children who ended up being schizophrenic, and their siblings who grew up in the same environment, similar in age, same gender, who grew up not to be schizophrenic. And then she took judges, research assistants working with her, and they developed a rating scale to rate the videotapes. Blind, you don't know, they don't know who is this kid. I mean, they know it's the purpose of the study, but they do not know, is this the sibling of somebody who will end up being schizophrenic, or will this person end up being schizophrenic? And as early as first few months of life, you can see, and some of the videos were done at age 4 months, you can see they were able to pick up the kids, the babies that later on develop schizophrenia. Lack of interaction sort of with the person who is filming, lack of sort of the curious look on your face, like you're really exploring, grabbing for things, they were able to pick it up, which is interesting. So this is probably well before parents express, you know, intensity of emotion. What do you do to a 4-month-old, you know? So it's interesting. It might be right there at birth and relate to aberrant development. So I think that the area of emotions is going to become a hot topic because very little was done, and it relates to cognition. I can tell you that the impairment in picking up emotions that we have seen in adult patients with schizophrenia is not related to their cognitive ability. So if you divide the patients, those who are very cognitively impaired or less cognitively impaired, they cannot read faces just as well. Okay? The patients with more negative symptoms that we discussed last time have more difficulty in reading emotions. So the patients who are more anhedonic, less involved, less motivated, have more detached, have more difficulty reading emotions. So that's emotions, so it's sort of it's right now developing, and it's an important topic to watch. And I think that while cognition has been emphasized in schizophrenia, Kraepelin and others have emphasized emotions, the blunted affect. Of course they did. It's just that we did not have tools to study it, and now we do. All right. On neuroimaging, or the application of methods to study brain anatomy and physiology, there are 2 domains in neuroimaging research on schizophrenia. One is anatomy, brain structure. The other one is physiology. And normal brain structure doesn't imply normal physiology. The 2 must be studied together to be able to make a meaningful statement. If the physiology is impaired, you say, well, maybe it's impaired because the foundations are shaky, you know? You must look at the 2 together. And in the study of neuroanatomy, the introduction of CT or computerized tomography has provided an unbelievable opportunity, lots of mileage. More than 100 studies were published on it to look at the brain ventricles of patients with schizophrenia. The ventricles is the largest body of CSF, cerebrospinal fluid, in the brain. And the question was, when you get a CT scan, it's like almost with a ruler, a planimeter, you could measure what is the area there. And the idea was, if patients with schizophrenia, they should have more CSF, cerebrospinal fluid, and less brain tissue, brain parenchyma. And so because technology was sophisticated just at the level of looking at one slice, a ventricular brain ratio, the ratio between the ventricles and the brain, this is what everybody did. And most studies have shown, although not all, that the ratio is higher in individuals with schizophrenia than in normal controls. Okay? Now, MRI, magnetic resonance imaging, has replaced CT scan. It involves no radiation, it provides volumetric measures, and you can look at cerebrospinal fluid, not just in the ventricle in the middle of the brain, but also in the sulci, the grooves of the brain. And I will show you some examples. All right. This is an example of an MRI. And what you get with MRI is that you get the dark region is brain tissue, the white region is CSF, cerebrospinal fluid. The brain is bathing in cerebrospinal fluid, okay? Now what you can do in addition to looking at it is you can develop volumetric measures. The brain is a volume. So the initial CT scan studies couldn't do volumetric measures. So they measured it just like with a ruler. But this is, I mean, it's better than nothing, but it's not the way the brain works. So this gives you an example of how with a computerized method, you can roughly delineate, this is like the ohms, the area delineated, and the computer as an algorithm that gives you an exact number of what is in cc or ml, the measurement of the structure you surrounded. And just to show you that this can be done, I'll just walk you through some steps. This is another example of how you can go slice by slice from the top of the brain to the bottom of the brain and not just look at one slice. The computer just brings it up on the computer screen and the investigator just makes, you know, with the mouse a circle around it, clicks, and you get the volume of how much brain, CSF, and tissue is under the demarcated area. And you might say, well, you just sit there and make a circle around. Is it reliable? If two people, two operators sit in front of the same scan and each one of them circles it around, do they come out with the same answer? Absolutely. This is the example of reliability. If you look at the whole brain, the total volume of the brain across all slices, operator 1 is one person. Operator 2 is the second person. Each one of them is sitting independently and looking at the same 10 scans at different times. The line in the middle that divides this rectangle is the equation line. It means if a dot, each dot is the volume for a person. If the circle, the little circle, falls smack on this line, it means that they've judged it, they've measured it to be identically the same. Look how close it is. I mean, it really can't be better. So it's very reliable, both for the brain and for CSF. And that's the first thing you have to do. You get fancy technology, and sometimes people begin to run with it before asking the question, what the heck do you measure? Is it reliable? You take two people in the room. Do they agree about it? If they disagree, the technology can be wonderful, but the conclusions you're going to say about schizophrenia are going to be very limited, because every time you measure, another number will come out. So what is the real thing, is the question. This tells you that it's very reliable. So if we are going to say something about the brains of individuals with schizophrenia with this method, the method is a good one, all right? That's what it tells you. All right. Just to show you that it's a good one, another step that is important, you take, schizophrenia is so tough, you take things that are easier. Normal aging. So they studied so much. And we know that normal aging, free of disease, is associated with decline in brain tissue. When we are born, we have the maximum number of neurons that we're ever going to have. From then on, it's just losing them with time. And what you can see here, we have studied a large sample of normal people from age 18 to age 85, normal volunteers, perfectly normal people. And then you look at the brain volume and you can see that it's going down. Each of these each circle is a woman, each filled circle, empty square is a man. Brain tissue goes down with normal aging, beginning already at the second decade. You know, in the late 20s, it's less than early 20s, down, down, down. Slowly, but goes down. At the same time, CSF, cerebrospinal fluid, is going up. The process is accelerated for men relative to women, and it introduces the question of gender differences that has been observed, definitely in normal, but also in schizophrenia. Women have some protective mechanism. Is this why, for example, women with schizophrenia present usually later, have a less severe course than men, are more responsive to treatment, they have more protective mechanism? Maybe, but this might give us a clue to the gender differences that we see in schizophrenia. All right. So now, with this in mind, you ask yourself, all right, if you plot every person with schizophrenia, and remember, they're free of anything neurological, just schizophrenia. If you plot every person with schizophrenia, you separate for men and women, because we know it's different for men and women, and controls is this, schizophrenia is that. What do you see? What you see, number one, is there's overlap. Don't expect that if you plot everything, that the brains of patients with schizophrenia will be over there, like there are different species, and normals will be right here. No, there's overlap. We look at all brain volume, most individuals with schizophrenia overlap the normals. Okay? So that's number one. The other thing that you see, and that's what well, you don't see it, but I'll tell you this. These are the homemade slides that we did over the week, but I'll tell you what it shows. You ask the question, okay, what happens when you look just at the ventricles? When you look at first, one of the things that we just found, and this is an sample of 81 patients with schizophrenia and 81 matched controls, similar background, socio-demographic education of the parents. What you see is that patients with schizophrenia have smaller brains, slightly, but significantly smaller brains than the normals. The other thing is that the ventricular brain ratio, how much CSF they have in the ventricle, the middle butterfly shape, to the rest of the brain is higher. So it confirms the early CT findings that were done just on one slice. Now you look at the whole brain, it confirms it, which is good. Then the question that we have asked is, well, is it related to clinical? The answer is that it does. How does it relate to clinical? What we have done, remember what I mentioned, is that for every patient gets an extensive assessment scales, standard scales, on the basis of all the information available, the history, the presentation, the follow-up. What we have done is, with a computer program, divided the patients into 3 groups based on the profile of clinical scores. Those who are the highest or negative. So the computer looks at all the ratings and says, all right, here are the people who scored the highest on the negative. Pull them out as one group. Those who are the highest on paranoia. On all the scales, they measured the highest on paranoid items. So they're more like paranoid schizophrenic. And the third group are the patients who are more Schneiderian. They measured the highest on hallucinations and delusions. So we've taken 3 clinical entities and have asked the question, are these entities, if you look at them, these subtypes, they're not DSM subtypes. Well, they're similar, the paranoid are. Are these subtypes related to brain anatomy? And the answer is that they do. The paranoid are the least impaired as far as brain anatomy. And it's interesting because we know from the studies that were done at Chestnut Lodge, following patients for long years, many years, Fenton and McGlashan, we know that the paranoid have the best premorbid and the best scores as far as, attaining some level of functioning. They have the least impaired. The negative are the most impaired. They have the smallest brain, the more CSF. And the Schneiderian are in between. Okay? So there is a relationship between the clinical features and brain anatomy. There is also a relationship that I do not have time with, that we are now looking at, between the brain anatomy and the neuropsychological functioning. There's a relationship. So you can see how, right now, researchers in the field are tying the clinical features, the neuroanatomy, and the neuropsychology. MRI studies have gone a step beyond that. And what they've examined is specific brain regions. What I've shown you or spoke about relates to the total brain, all brain volume, CSF volume in the ventricles and the soul side. How about particular regions? The regions that have been most examined, and it's not accidental, are the temporal lobe and the frontal lobe. because these are the regions that have been tied to cognitive dysfunction, remember, abstraction, attention, memory, and to the features of schizophrenia. The negative features, presumably more frontal lobe dysfunction, hallucinations, delusion, temporal lobe. And there have been a number of groups that is the same method that I've shown you have now gone, and rather than demarcate the ventricles, have demarcated the temporal lobe. So they've circled the temporal lobe and have come up with what is the volume of the temporal lobe. And what they find, and this has been done at Hopkins, has been done at Harvard, has been done at NIMH, we are now doing it as well with the same results. What we find is that the temporal lobe of individuals with schizophrenia is smaller in volume than for normals. Furthermore, the left temporal lobe is smaller than the right. This supports the laterality hypothesis, implicating more left than right. It's smaller, significantly smaller. And if you ask, does this relate to hallucinations and delusions? Yes, it does. The smaller it is, the more severe the hallucinations and the delusions of the patients. Yes, it does. So you can see how from going from global symptoms, the total brain, we are now focusing on specific regions that based on the clinical features, for example, hallucinations and delusions, the neuropsychological impaired learning and memory, we look at the anatomy and we say, yes, the anatomy corresponds. So a story is now emerging. And the fact that if you look at the total brain, I thought if you're at a distance, you don't see as much or it's confusing, doesn't suggest that there's nothing there. It just suggests that you have to look a little bit harder and push the technology so you can go farther. So in one way, the study of schizophrenia is now making progress because the techniques are available. We could have talked until we are blue in our face about the temporal lobe, but if we can't measure it, it remains an hypothesis. Now that you can measure it, you can check it and say, oh yeah, it makes sense, or it doesn't make sense. For the frontal lobe, it's less clear. There have been a number of studies that have measured the volume of the frontal lobe and tried to relate it to being deficit or non-deficit patient. It doesn't. There is less of a consistency there. Okay? So studies of the temporal lobe consistently show decrease in temporal lobe volume, more on the left than the right, relationship to hallucination and delusion. Studies of the frontal lobes, some show less volume, some don't. And some who have looked at the volume and tried to relate it to negative symptoms didn't see any difference between those who are negative and you think the frontal lobe is involved. Maybe, it might be, the frontal lobe is tough to measure. It's such a heterogeneous region. It has so many subsections that maybe looking at the total region is not the way to go. We have to look at smaller regions. And then what you need is really more technological development rather than lump everything. Because it's not like the frontal lobe does the same thing. It is a specific region, and each one of them is a little bit different as far as its structure and its function. All right, so that's one possibility. The other possibility is that the nature of the patients. It's such a heterogeneous disorder. For example, if you just, when you follow patients for a few years, some of them don't change, but some of them change, at least has been my experience, unbelievably. I mean, I will call them deficit initially, and then after a few years, they're holding a job. You know, not a high-level job, but every morning they're going to work, they come in from sitting in the office and barely looking at me, then now when they come in, they shake my hand. That's a tremendous progress. They're not deficit anymore. And if you'd have asked me, would have I predicted a few years ago when I took this patient, this is how they will look? No. I marked them deficit. In our rating scales, every year we mark again and use a subgroup that I said, you know, they're responders, whatever was going on that didn't let, I don't know what it was, potentially many things, but now they're moving. You know, they're living on they're not, you know, you can relate to them. There's like light at home. So what are they as far as the brain? We don't know. We need studies that show, this is why you need a longitudinal approach, studies that say this is how they were, and they've always been like that, versus they started here and they've changed. So the work is cut, the technology is now there, we just need to have large samples and characterize them and follow them. All right. This summarizes all the bad slides. All right. I promise next time they will be better. All right. On neurophysiology. Neurophysiology is how the brain functions. And there have been a number of measures that have been used. I will mention them all, but just take examples of a few because it's too much. Again, it's like a topic all by itself. The oldest one that has been applied extensively to schizophrenia is electroencephalography with EEG and evoked potentials. EEG giving a topographic reading of brain activity, evoked potentials providing a stimuli like light or auditory stimuli and watching to see what is the brain's response. The amplitude and where does it come from. This has been applied most extensively because it antedates the more recent developments in neuroimaging. It's cheap and it's clinically available. The literature on it is so large and it's so complex that it's very hard to say a general statement about it, except that as methods in EEG have developed for quantification, and as we have learned more about the other neuroimaging techniques, you can see that there is good support so that a lot of EEG studies, which now specifically look at the temporal lobe, say yes, there is impairment in the temporal lobe. But you have to know where you are looking, because, I mean, it's so much data coming that it can be confusing. So this is EEG and EP. It's not in the forefront anymore because there are better methods that have replaced it. The other methods have looked at cerebral blood flow, the rate in which blood flows in the brain, glucose metabolism, the rate of consumption of glucose in the brain, and receptor function. PET, positive emission tomography, is the most versatile method for doing all of this. It can measure blood flow, it can measure glucose, and it can measure receptor function. SPECT, single photon computerized emission tomography, can measure blood flow, and more recently, receptor function. The difference between the methods are major. First, I will say what are the commonalities. In all of these methods, neuroimaging physiologic methods, except for the EEG that I'm now putting aside, what you do is that you administer a radioligand to the brain. So you administer oxygen-labeled water. You administer glucose, sugar water, which is labeled with fluorine. This radioligand fools the brain. It's been taken up by the brain, sort of being eaten up, and when it comes to the brain, because it's radioactive, it's a tiny amount, it's less than a chest X-ray, it emits gamma rays, specific radioactive rays. These radioactive rays are counted by detectors that are in the scanner. So every time a ray is emitted, it's like the computer clicks, like tick, tick, tick. The more tick, 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 the more rays are there. If there are more rays being emitted there, it means that the brain at this region is just working harder and consuming more. Hence, it has increased activity. If very few rays are emitted from a region, it means that this region is not busy. So you can see that the greater the activity, you assume that the greater the count rate, you assume that the greater the physiologic activity. And what the computer does is that it recreates a picture in the scanner. The scanner is hooked to a computer where all these pics, the counts around the head, are translated to a picture, black and white or colored picture, and I will show you some. Here we go. This is an example of a brain of one person. This person is studied in the PET, positron emission tomography. What is measured is glucose or sugar metabolism. And what you see here is multiple slices of the brain obtained like that from top to bottom. There are multiple slices. So there's a period of injection through a venous line, uptake. The length of uptake depends on what radioligand you are using. For glucose, about 40 minutes uptake, and then you scan for 20 minutes about, okay? And what you get is a number that you can talk about, all right? So you can talk about the average brain, but then you can look at region. You can look at the front, the rim in the front. You can look at the temporal lobe right here on the side. And what you can get is what is the rate of glucose metabolism in each of these regions. If you use oxygen, you can say what is the rate of blood flow in each of these regions. You see? So you get an accurate reading for this particular time of study. And then you can ask the question, well, exactly what we have done for anatomy. How is this related to the clinical features? Do patients who have very negative symptoms have less glucose uptake in the frontal lobe? Do patients who have hallucinations and delusions have more or less, probably more, glucose uptake in the temporal lobe? You can see how you can tie in physiology to the clinical, to neuropsychology. Our patients who are most impaired in memory have the worst metabolism in the temporal lobe. So this can easily be linked. And this is just to show you that when you do just physiology, you are not done. You cannot say on the basis of the physiology, well, I know the frontal lobe is up there, so let me mark it. You have to superimpose it on the MRI of the person, on the anatomy. And then you can mark the boxes, the area of the brain that you are interested in. And that takes a lot of time. It's labor intensive. It can take you all day just to mark one brain. That's tough. So this is an area, it's called co-registration. Putting together for every person their physiology and anatomy. Because the brains don't look alike of people. So you can't just say, well, this looks to me like the temporal lobe, and you mark it. Maybe it's not. So you have to base it on the anatomy of that person. And the computers should enable you to superimpose it. It's very tough to do, computer program. It's tough. So this is what the field is currently working. But if you ask me to summarize the studies in PET, glucose metabolism, and in blood flow on schizophrenia, I will say that while not all conclusive, and it's a relatively young field, this part, 10 years, not more, is that what we see is that the studies support the 3 dimensions I started with last week, namely impaired anterior relative to posterior function with less glucose in frontal lobes in some studies, laterality, the balance between the 2 hemispheres, especially the temporal lobe, is not normal. And the third, that subcortical to cortical ratio is not normal, with more subcortical activity than what you see in normals. All right. Another thing that you can do with PET and with SPECT is measure neuroreceptors. And this is just an example of that. This is N-methylspiperon, which is a dopamine type 2. Remember we spoke about the different dopamine groups, receptors. It's a dopamine type 2 receptor blocker. It's like the neuroleptics. It's like haloperidol or Haladol. It's similar to it as far as structure. And when you take a normal brain, you take a normal person to do this study and you administer this pharmacologic agent, you can see that it goes where it's red to the basal ganglia. It goes to the middle of the brain where the receptors are. This is what the dopamine receptors are. If then you give this person Haladol, Haladol competes with spiperon that was already in the brain. And it fights with it for occupying the receptors. And what you can see now, in the middle, the receptors are now a little bit greenish. because Haldol displaces N-methylpyperon. So this is sort of a proof or a way to show that these ligands indeed go for the receptors and that you can create competition in receptors in the brain. Now to show you what happens when you take a group of patients, and these studies were done at Hopkins. When you take a group of patients and you look at how busy, how full and active is the receptor, you look at normal people and in patients with schizophrenia. The normal people, older, each circle, filled circle is a person. Note that there aren't that many circles there. These studies are very tough to do, extremely expensive. It's thousands of dollars per one person. And it needs a whole team, a whole crew, radiochemist, physicist, a camera operator. It's like a big production to do one person. All right. So if you look at normal people, you can see that for the young people, they have more receptor activity. So receptor activity declines with normal aging, just like brain volume. If you look at the patients with schizophrenia, they are divided into two groups. Neuroleptic naive, never treated, so the receptors have never been touched by antipsychotic medication, and those who have been treated. And you can see that in both groups, there's an increase of activity of dopamine receptors. This supports the dopamine hypothesis in schizophrenia, namely increased subcortical dopamine receptor-rich activity, and the efficacy, hence, of antipsychotic medications. But just as this group was coming out with this finding, another group, another part of the world in Sweden, the Karolinska group, came out with a statement that in their study, there's no difference between the patients with schizophrenia. They made the same dots, circles for each patient. They overlap. The patients are not the same. The patients in Baltimore diagnosed with schizophrenia are different than the patients in Sweden. The ligand, the pharmacologic agent that they use is entirely different. The camera that they use is different. How they quantify, all the modeling that they quantify is different. So basically, we don't know if it's true or not. It's just the beginning, but the field is moving in this direction, and it is very likely that we will be able to understand potentially responders, non-responders by studies like that. If people don't respond, and if you do a receptor study and you see that it's not going there, for whatever reason, their receptors are not taking this drug. You can save yourself a lot of effort, but it's so expensive that I'm just saying that down the road, in the future, we might be able to understand better. For example, even clozapine, if we can develop ligands for that, why do some people respond to clozapine and some not? So the potential is there, it takes an extremely long time to get these studies. Okay. So for the neuroimaging, to summarize, is MRI has replaced CT scan, demonstrating that there is more CSF in the ventricles in patients with schizophrenia. Regional studies implicate the temporal lobe. 4 functional studies that are proceeding in 2 sort of parallels. One is receptor work, which is not conclusive yet, but it's an exciting area. The other one is the study of blood flow and metabolism. One thing that I did not mention is that in the study of blood flow, in the study of receptors, what you use is a pharmacologic probe. You perturb the system by administering a ligand, a pharmacologic agent, which is similar to antipsychotic medications, and you see where does it go in the brain. You try to block it, you measure it, etc. When you measure blood flow, you can also introduce a probe, a neurobehavioral probe, which is one of the things that we are doing and others are doing at NIMH, at Iowa. You give a task that you know that patients with schizophrenia have trouble with. For example, memory. You know, I just finished telling you that memory is no good. They don't remember, they don't learn, and they don't remember. So it barely goes in and out, which is part of the difficulty that we have with patients and suggest as implications for rehabilitation. At any rate, what you can do if you say, why is memory? What happens to the brain when you give them memory problems? Well, you can give them a standard memory test to remember words or faces and measure blood flow. And one of the things that you do is that you see that for normal people, when you give them a memory test, the brain region that has the highest activity in blood flow is the temporal lobe. That's the right region, not in schizophrenia. It's like the whole brain gets active. It's like an effort. They go here, they go there. But no brain region takes control over the issue, namely being engaged in a memory task. Maybe that's why they do so poorly. Maybe what happens to them developmentally is that this brain region, which is so susceptible to perinatal stress, never reached mature development. And later on, when they have to engage in tasks, this brain region cannot rise to the occasion. So what you have is that there's an increase in blood flow when you ask them to do something, but there's no leader to the ship, okay? And there's no leader overall in the frontal lobe, and there's no leader for a particular task. So that's another approach to try to understand, give a task, and see what happens to the brain. You challenge the brain, and you see how normal people react to challenge, and how patients react to challenge. And you see that they do not react the same. Okay. The only way, this is something that I want sort of to impress on you, is that the major way, regardless of all the sophistication in technology, in medicine, the major way for really understanding pathophysiology, knowing what was wrong, there's one gold standard: post-mortem. The patient has cardiac illness, has cancer, whatever it is. How do we know? You know, at the end, which organs were involved, how do they react, what happens on a cellular level post-mortem. There's no other way. That's the goal. Clinical pathological correlation. That's it. That's the name of it. Now, fortunately, in medicine, we don't have to wait so long. There are CAT scan, MRI scans, the whole thing, perfusion studies for any organs. So you can intervene and help patients much earlier. Hence, people live longer and a better quality of life. You know, it's not that the air is getting better. It's just that medicine has improved. In brain, it's exactly the same. It's just a little bit tougher. Because remember the beginning of the story, the brain is very complex. For schizophrenia, as a brain disease which affects 1% to 1.5% of the population for lifetime, we know relatively zilch from post-mortem studies. Alzheimer, that has become fashionable much after schizophrenia, there are brain banks, I mean, to the rim. And everybody's talking about the autopsies and conferences on it. Endless, not on schizophrenia. I think that unless it is done in schizophrenia, we will never reach the promised land with schizophrenia. It's essential, but it is extremely difficult for people to think about, you know, it is a brain disease. Well, we have to look at the brain. So, there have been, in the past, studies that have been done. Schizophrenia has been called the graveyard of neuropathologists. In other words, if you want to die professionally, as a neuropathologist, do schizophrenia research. You'll never find anything. This is turning around for two reasons. One is that I'm not the only one, but others recognize that it is important, and some people here have helped me, Edith, and some people that I recognize in the room, in pushing it ahead in the state of Pennsylvania. The others is that there have been unbelievable advances in the neurosciences that permit to study the cellular structure in ways that a few years ago were not even conceived. That's how much there's so many breakthroughs that you can really look at the function of specific enzymes and detail what is the chain, what does it happen. And this, no matter how good brains you had before, you just couldn't do it. All right. Most of the studies on schizophrenia, post-mortem studies, were done retrospectively. In other words, somebody with schizophrenia in their lifetime died, and investigators are doing brain research, knew nothing about the patient, never saw the records, never spoke to anybody who took care of the patient. And what they got was a brain with 3 lines attached to it, X-year-old man or woman, treated for 50 years, period. That's it. Good luck. We'll never make progress with that. Relative to that, when you talk about Alzheimer, you know, the onset of illness, the progression, details, unbelievable. Partly because you're dealing with a disorder that many times is after age 70, 65, 70. The person did well before, the family. You know, it's easy not with schizophrenia. The case that I'm trying to make is for prospective studies. And we have begun it in this hospital, some of you are not even aware, and then it has spread to other hospitals in the Commonwealth of Pennsylvania with the support of central office. And I'll just mention some of the issues. What are some of the antemortem issues? By definition, you're dealing with elderly people. Although the rate of suicide in schizophrenia is about 13%, that's high. The rate of suicide is high in schizophrenia. It is not, it's something that is unfortunate and it's not predictable. So there are some centers who look at suicide victims, and then they do a psychological autopsy, trying to recreate the history. But most look at nature, namely at elderly people. There's a question of assessment, evaluation of the elderly. There's a question of the effect of medication, exposure to medication from the 50s to the 90s, at least you're talking about potentially 40 years. What does it do to the brain? And there's a question of how do you register? I mean, there are lots of people like that, but how do you get a hold of it? And this is what we have tried to do in the Commonwealth. For the post-mortem end, you're talking about brain acquisition. Is it done in a standard way? Exactly followed to the, to the T with every detail of a protocol. And how do you process the tissue? There can be marked variation in that. And what we have done is that we have collected, up to now, in the past 3 years, 15 brains of individuals from the Commonwealth of Pennsylvania, Harrisburg, Norristown, South Mountain, and Clark, of individuals who have suffered through their lifetime from schizophrenia, and with the permission of the family, once they died, and most of them have been in the late 80s, 90s, their body came to the University of Pennsylvania, and the research grant paid for it. So it's no expense to the Commonwealth or to the family. It's the grant, the federal government supports it. We have a grant that competed for it, and it was recognized that this is an important area. And then it's done in a standard way. And what I can tell you is that for these 15 individuals, if you look at the brain grossly, it looks perfectly normal. It weighs very similar to normal, perfectly normal, free of disease. They do not have Alzheimer. They do not. If we look at the brain microscopically and look at plaques and tangles, which is the hallmark of Alzheimer, the brain is free of them in an unbelievable way, clean. It's important because one of the things that we do, and we've done here with elderly patients, is evaluate their symptoms. The way we do with young, but very brief, because they cannot tolerate lengthy procedures. And we have evaluated the cognitive ability. The cognitive ability of elderly people with schizophrenia that we have studied here. And by now, we have almost 30 people, compared to 30 elderly controls from a similar background. It took a long time to recruit the controls, people in the 70s, 80s. They pattern the profile. Remember I showed you the profile of neuropsychological functioning, most impairment, learning, memory, in young people in the 20s with schizophrenia. The profile of the elderly is worse, but the shape of it is remarkably identical. Yet, if you look at the temporal lobe, it doesn't have plaques and tangles. They have impairment in memory and learning, just like Alzheimer's patients do. But in Alzheimer's patients, what you find post-mortem is that the temporal lobe, hippocampus, is the region that has most of the plaques and tangles. In these people with schizophrenia, no. So it's something else that can explain, needs to explain the dementia of schizophrenia. Why are they demented? Why do they have such impaired cognitive abilities? Similar to Alzheimer, but it's not Alzheimer. We have proved that it's not. And one of the things, just to illustrate to you, oh, well, I didn't put it in. But one of the things that we are doing is we are looking at specific brain regions, probing them in a very specific way with specific proteins. And based on this, I can tell you that there are a number of laboratories now that have confirmed what we have found. And all of these studies are in the last 2-3 years, is that specific regions in the hippocampus and the temporal lobe show impairment. There's a decrease in cells. The cells, normally cells have dendrite, neurons have dendrite, and these dendrites are like, like branches coming off trees that communicate with each other. In the patients with schizophrenia, in this particular brain regions, the branches are like disheveled. They don't stand out normal. They're sort of like little, they look like after a storm. That's how they look like. This can impair communication between cells. And these are very critical regions in the brain that are important not just for learning and memory, but they relate to the frontal lobe, to the amygdala, to many, many important regions. This is likely to occur early in development. Early in development. The last issue of Archives of General Psychiatry has 2 articles that suggest temporal lobe post-mortem from 7 brains from California, temporal lobe and frontal lobe abnormalities in patients with schizophrenia. And these are seen on a cellular level. So this is where the knowledge is now. So you can see how we are beginning to build a case from we are beginning to build a case from phenomenology, looking at negative symptoms, hallucinations and delusions, neuropsychological functioning, abstraction, attention, planning, memory and learning, to neuroimaging, volumes of specific regions, receptor function, to postmortem. There is a literature on receptor function postmortem as well. You can look at it. So what you can do is postmortem, you can look, but you can be more accurate than with the neuroimaging. You can look at anatomy on a cellular level, and you can look at receptors. So you can examine dopamine receptors as well. So the technology is there. What is missing and what can be achieved in a center is the integration from the human level of description of function, intervention, to the more cellular level at the postmortem, looking at schizophrenia across the lifespan and asking where and why did it go wrong. What I'm saying, it went wrong very early in utero with genetic predisposition. So by the time we get to see them, what we are trying to do is ameliorate a signature that they're coming into this world with. And the patients that you get are the toughest patients. Not all of them are like that. You get the toughest patient. The question is, why are they the toughest? Is there more genetic predisposition there? Was there insult, not just one, but multiple? And these are answerable questions. They are answerable questions by going from all the stages. You can't skip a stage, that's the point. And the questions are answerable because, for example, we can take patients who end up at this hospital and are young, in the 30s, and people who live in the community with the family. and are 30. Very similar, but they have less profound symptomatology. And put them through the neuroimaging and see, are they different? What is it? For some patients, the family support can make a difference. I mean, some families can just have the means and the patience and the ability. They have one child and they put all the effort, and this child is very, very sick. It doesn't do anything. And other families can't. But there is more than just that. There's more. Just that, and we'll come back to what I started with, that it's most likely more than one illness. And it's just there are some common features. And it might well be that the patients who are here, are those who have gotten the worst form of it relative to others. Are there any questions? Yes?
You're saying that you're predisposed to schizophrenia. Are there things that kick the disease in then, or is it a linear sort of thing that's going to eventually take over? Or?
It's not, well, I mean, the question that you, in a way, you're asking, is it programmed, and then almost no matter what, it's going to happen at a certain age, at adolescent? Probably, environmental stressors play a role as well. But to tell you that, we know what, I'm not sure. But it might be that this is what will make a difference between somebody who is just going to be a mild form or spectrum disorder to somebody who is going to have full-blown. We don't know yet. Yes?
In the first part of your lecture, you were talking about, the specific mental cognitive tests, memory ones.
Yeah.
The means were much lower. There's only one in clinical work. This wasn't made by Raquel and she was years ago.
Yeah.
That when you're talking about these means, you might have a patient that is schizophrenic that maybe didn't show particularly that pattern at all, but what they noticed was the scatter and the intra-obsessed scatter, or these more diagnostic ones, where if one just looks to say, well, those memory ones are down, maybe something else is down even further for the individual, or something way up,
That's correct.
It probably has to do with the attention factors, or second, maybe even the negative symptoms.
Okay.
Imply that attention could drop in the middle of a comprehension, or it could be, or they might be very high in mathematics, but
Okay.
very low on attention.
Yeah, these are all very, very methodological issues. There are different ways of trying to tackle them. One, for example, is that to compare memory, I mean, attention, if people don't attend, and patients with schizophrenia do have impairment in attention, then the rest of it, I mean, you don't know what you measure. They just don't pay attention to what you're talking to them. What you can do, you can tackle it. What you can do, for example, statistically, you can co-vary attention. You can say, given that this is potentially the effect of attention, how will memory look like? And we have done it. Memory is still impaired. Another thing that you can do, you can divide patients into groups. Those with the worst attention, those with better attention. Is memory not impaired in those with better attention? No, it's still impaired. So attention contributes, but it doesn't explain the total picture. And another thing that you mentioned is correct, is, the relationship to symptoms or to negative. This is why longitudinal studies are needed. So you just take a glimpse of a patient at one point in time and make your whole story, but repeat it. And what we have done, we repeat it 2 times. At intake, about 8 weeks after that, when they are less acute and treated, and 1.5 years to 2 later. And it changes very little. Attention changes, not memory. Not enough. A little bit, not enough. They don't become normal. Another thing that we have done, I forgot to mention, is that to use the genetic strategy, we look at siblings of probands. We brought in, now we have 8 we've studied already. There are more lined up. Siblings of people who have entered our center with schizophrenia. The siblings are well. They're functioning adults. Their memory relative to the other abilities is also impaired. The profile is impaired as well, which is interesting. These are normal people. They do not come, they're normal people. Their memory is somewhat impaired. So we'd like to get it a larger series, and we are doing MRIs on them to see what is the volume of the temporal lobe. We know that in our patients, the volume of the temporal lobe is decreased, the left. We want to look at the siblings and see how much might be explained by genetics, because there's a lot of normal variability. Another thing that we are doing that I mentioned is that to go and look at people for whom identify people who are now in their late 20s, where we have prospective early development, and look at their siblings as well, so that you can begin to tease it apart. So these are questions that are answerable. It just might take 20 years to answer some of them, because it requires a lot of studies, because they're tough questions. Yes?
Is anyone to the point yet that they would be using medication with children? Medications like Tylenol, things that would be used in a young adult for one with schizophrenia. You mentioned that time there, surgery, been complete a couple months.
Yes, yes.
Has anyone started bringing this to
No. The close, yeah, no. The question was if intervention, if the disease is picked up earlier, if intervention can be done earlier. I don't think it has reached this stage yet. It is just.
you see that in the future, maybe the medication
Yeah.
would help, but then you also
Yeah. The question is, if you have a high index of suspicion that somebody is at high risk, can you intervene in some way, like, Head Start, but in a sort of a milieu that will try to ameliorate as much as possible? This is really ultimately the goal. I think that the goal is really try, if we can understand better the disorder, then the hope is that the treatment will be more effective and with less side effects, and that can, yes, that might be years away, yes. I think it will come. It's just that the much work, groundwork that is needed to guide the treatment, yes. But this is really the goal. Yes.
Many unknown studies going on regarding patients who develop narcolepsy with use of medication.
Yes, there are a few studies that are now going on. Other studies that are going on patients with tardive dyskinesia. There are a few studies that are currently going on. Once you get a handle of the technology with patients without tardive dyskinesia, and you see what is schizophrenia without tardive dyskinesia, then the next question is, here is a subsample of patients who have tardive dyskinesia. Yes, there are a number of studies going on, too early to tell, but there are a number of studies going on at a few universities that apply imaging, neuropsychology with tardive dyskinesia, yes. It's an area that we are interested in as well, because it is a complication of treatment, and if you can identify who might be at risk, maybe the treatment approach might be different. It might be that with patients like that, for example, you'll move to clozapine much earlier. Or you will try to use other non-traditional medications. After you want to expose them for a long period of time. So there are studies like that currently going on. And I think that in the next couple of years, more will be available in the literature. Yes. 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 Yes, yes. Not all. The question was what regions of the temporal lobe are decreased in volume. Not all the studies have looked at the same region. But whatever they've looked at, some studies have looked at the hippocampus, hippocampal gyrus, cortical, whatever has been looked is smaller. So it looks like global. Okay? Thank you very much. Thank you. Thank you.